Good afternoon, everybody, and welcome to our SEVA VentRounds. And today we're gonna use a case that we had in the IC. There's the modes in which the pressure that the ventilator delivers will remain constant in spite of the PMOS that the patient is delivering. And we know, and we have said it many times, that the P-vent is not controlled perfectly by the ventilator, but they were going to try to maintain it at the set level in spite of the pressure that the patient is generating. And the two classic examples are pressure control and pressure support, in which there's set point. You set the amount of pressure that has to be delivered by the ventilator, and that's what you're going to see. And the final one is an ascending relationship, in which what you have is, as the patient starts doing more effort, the ventilator will deliver more pressure. And so this proportionality is in the ventilator, the modes that have a proportional or servo targeting scheme. And the two classic examples are PAV, proportional assist ventilation, and NAVA, the neural assist ventilator assistance. Roberto, comments?
Just quickly to say that in the adaptive pressure control modes, the ventilator reduces pressure, but it doesn't know the difference between increasing compliance and increasing effort, or both. It just knows it doesn't take as much pressure to deliver the target tidal volume.
Yeah, absolutely. And I also want to highlight another thing that sometimes we hear is, I mean, and this not necessarily has to be a negative statement. And so you may have patients in which you want to have some of these come down, the amount of support that they're getting. And so it depends on the goal of mechanical ventilation or the protocol that you're going to use on how to do that. So these types of relationships is just something that you have to be aware of, not necessarily a negative thing, just depends on how you apply it and use it. Rob?
That's right.
All righty. And I see a comment from Ariel about PCIMB-SS and PCIMB-2SS as also examples, of course, of this constant relationship. Thank you, Ariel, for putting that there. All righty. Okay, device, allow me to change. There. So this is the example that I have put here today for all of you to assess and to learn together. This is a screenshot of a patient, and it's not, you'll see that we did this from the exporting screen from the ventilator, but it contains the same information. On the first line, you have the pressure waveform, then the flow waveform, then the volume waveform. And so let's start by reading this through and start with the tag. And so if you can enter on the chat, what do you think is the tag for this mode of ventilation? Again, have no fear. This is where you test yourself. All righty. Excellent. So I see a large amount of our group is starting to recognize this as pressure control, and that's correct. This is a pressure control type of breath. So although it says that it's PRVC, and if you go by the name, you're probably going to make an error. It says pressure regulated volume control, but it has nothing of controlling the volume. Essentially what it does is it's controlling pressure during inspiration, and you can see that because the flow is variable and the pressure is essentially non-existent, and we'll go over that in a second. Then it's CMB, and CMB stands for continuous mandatory ventilation, and in this case, the breaths are mandatory, even though they're triggered by the ventilator. Triggered by the patient. they are cycled by time, and meaning that in PRVC, you're setting an inspiratory time. And so every breath ends at the set I time that you put. And finally, the targeting scheme, which is adaptive. And adaptive meaning that you set a target tidal volume. And that's where the confusion usually comes, that you set a target tidal volume, but that is a target. And target doesn't mean that you control. Target means that the machine is going to try to achieve that target tidal volume that you have set. And so that's what PCCMBA stands for. Rob?
Yeah, just two things. One, if you've never heard of PRVC and you don't have a clue as to even what ventilator this is, if you have the ventilator mode map phone application on your phone, you can look it up because several ventilators use that terminology, PRVC. And another clue for you is the adaptive targeting scheme is never used with volume control, because in volume control, you directly set the tidal volume and the inspiratory flow. Whereas in adaptive pressure control, you set a target tidal volume, which is an average volume over time. It's not the volume within any particular breath.
Excellent. So the next question that comes, and yes, Hara, you talk about VC plus, and that's one of the other names that this mode has in the literature, in ventilators. So Ariel has put there VC plus, autoflow, APV or adaptive pressure ventilation, PRVC. All of them are the same thing. So thank you, Ariel.
Volume guarantee is a term used a lot in
Yes.
pediatrics.
So it's one of those things that the reason why the taxonomy exists, because you cannot make one out of each one of these names. They are more confusing than anything. So the next question for all of you is, what is the load? As you see, this is the load elastic, resistive, or PMOS. Excellent. So there's a high amount of PMOS coming in, and during inspiration, there's no question that the main load is PMOS. And we know that for multiple reasons. But remember, when you're controlling pressure, even though the pressure waveform is very abnormal, your eyes will go and look at the flow. And the flow, instead of having that beautiful exponential decay that we want to, you have this deformation that moves away from that exponential decay, and that is a manifestation of PMOS, meaning that the patient is exerting effort. And similarly, during expiration, you, instead of seeing that exponential decay, you see this activation of the expiratory muscle. So the patient is doing effort to inhale and to exhale. So great rapid read. So now that we have achieved that, we're going to start reading now our patient ventilator discordance in order. And so the first thing that we will read is the trigger. And so the question for the audience is the trigger early, late, false, or failed? And Javier, I'll answer your question in a second. Well, more than a second. Let's hear what the trigger we think that it is. Well, what people answer. Well, people answer. No, not the type of trigger, Ariel. What is the type of trigger? The PV discordance. So is it no early, late, false, or failed? And yeah, in general, you can see that the patient is triggering, and it rapidly triggers the flow. It crosses baseline, and there's no evidence of any pause before or before this. Even though the pressure drops, you can see that it drops and it rapidly pressurizes, which means that the ventilator is trying to maintain the pressure where it should. So I think in general terms, I agree that this would be a normal trigger. So there's evidence of PMOS and the ventilator is responding as it should. Rob?
That looks good to me.
All righty. The next item is the inspiration. So is it normal, over assistance, under assistance? And I know that severe work shifting falls under assistance, but what do we see here? Is there severe under, is there under assistance? Yes, there's severe work from the patient, severe work shifting. Very good. I mean, I see that everybody recognized this very well. So this is a classic question. So the PEEP level was 16 for this patient. So and actually I put a cursor where the PEEP level was, but we'll go over it in a second. But it was 16, so you can see that at this point, sorry, that the patient takes a breath in and the pressure actually goes below the baseline. So this patient, even though it's on pressure, is generating so much effort that the ventilator cannot keep the pressure. And then the end of the breath comes and the patient starts relaxing and the pressure will go up, and then there's expiratory effort and the pressure goes up. So if you imagine a baseline, and I draw a baseline right here with this line, you can see that the pressure is below PEEP. And so this is definitely severe under assistance. So there's severe work shifting. Rob?
It's worse than that, because when the pressure drops below baseline, then the patient is doing work on the ventilator instead of the other way around. So theoretically, this patient is doing more work than if you just disconnected them.
Mm-hmm. Right. So let's talk a little bit about the cycle, and this usually creates a little bit of anxiety in the group. How do we think the cycle is? Normal, early, or late? All right, I'm seeing some answers come through. Yeah. So remember, because we're controlling pressure, we look at the flow waveform. And if you look at the flow waveform, even though we're controlling the I time, you can see that the change of flow from inspiration to expiration really occurs really well. And there's no pause on it. There's no little shelf that would tell us that this is late. And if we look at the expiratory flow, I mean, this patient is going from inspiration to expiration. So you don't see the classic peak, but it doesn't look like the patient is inhaling during that period of time. It looks like that this patient is going from inspiration to active exhalation. So I say that this is a normal cycle in this patient in particular. This spike that we see on the pressure waveform is because the muscles, you're going from active inspiration to exhalation, and the ventilator is trying to control the pressure, and it's not a perfect pressure controller, so you'll see these behaviors. Let me see, I saw some comments come through. Yeah, so the spike on pressure is it's not an optical illusion, but it's a manifestation of an imperfect controller on the pressure. Roberto?
Yeah, and because this is CMV, meaning that every inspiration is preset time, inspiratory time, it's really unusual not to see some sort of cycle dysynchrony when a patient's huffing and puffing like this.
Mm-hmm. So yeah, that's correct, Ariel. And this is a common misconception that we see the spike and we immediately say that this is an late cycle. And I would again take you with your eyes to look at the flow waveform. And granted, if we had a microscope and could increase this massively and see, there is some delay and pressurization, whatnot, but this may not be as relevant as we think about them. And finally, expiration. We already talked about the expiratory work, so I'm going to underline it here. So, sorry, this machine keeps doing that. So at the end of this, we have a patient on PCC-MBA with high respiratory effort, in which the trigger is normal, there's severe under assistance, the cycle is normal, and there's expiratory work. And a common question that I get is, well, it looks okay, the patient. I mean, so why don't we leave it there? I mean, you could argue she's breathing 30 and it's pulling 700 cc's. But assuming this was, I mean, with a PEEP of 16 and actually the FI of 2 was 60%, many of us would feel pretty uncomfortable with letting this patient breathe throughout. But the question that I would get is, how do we measure the amount of effort this patient is doing? And this may, evidently at this time, we don't have perfect cutoffs and thresholds, but it's important to measure that we have some threshold that tells us that if the work is very high. So what would we use to assess the amount of PMOS that it's occurring? So a good amount of people are entering right now. One of them is the PO1, and that is a good marker of respiratory drive, meaning how strong is the neural impulse. And POC is probably a marker of the respiratory effort per se. So I thought that this would be a good example for us to show you how a POC is done in this ventilator. And actually, work that we're doing right now is to try to figure out how ventilators behave when we measure this. But I want to demonstrate here. So in this ventilator in particular, you have to do a recording and then go to the recording and do a post analysis of what you did. And essentially what you do is you do a random expiratory pause. So you don't tell the patient anything. You just go and press the button, and when the patient does one effort, then you release it. You just get the first one. And then you measure the pressure at the baseline. And as I told you, the PEEP was 16, and you can see that my cursor is right over that period in time, and it tells me that the pressure is 16. And then the next measurement that I do is at the bottom, and here I cannot see it, so I just grab my cursor and start moving it, and I will look at the pressure measurement, and I will see where it was the most negative. And here the most negative was -18. And so that means that the patient is going from a airway pressure of 16 all the way to a pressure of -18. So the patient is generating 34 centimeters of water of PMOS effort. And that's what at least the airway pressure is showing when we do that occlusion pressure, which in prior publications has demonstrated to correlate pretty close to the esophageal pressure measurement. And there's some variables for adjustment about what you actually see in the lung, but I would say that this, by all measurements of effort in a patient is pretty elevated. So, comments, Roberto?
Yeah, just to say that not all ventilators perform the same way. For example, on the PB840 and the 980 machines, if you try to do an end expiratory hold and the patient makes an inspiratory effort, then the maneuver will be aborted because it thinks that you want to do an auto PEEP, and you can't get auto PEEP if you have PMOS, right? So the only way to get the POC in this situation is, like Michael pointed out, you switch to the NIF maneuver. And then in that case, it's basically a NIF. What you're trying to do is a NIF at end expiration. So there's some timing issues involved there. The point being that it's difficult to say that there's one technique to use on all ventilators to get the POC value.
Yeah. So in terms of what to do with this type of information, I always will come back to what is your goal of mechanical ventilation for this patient. And if your goal is safety, as it could be implied by the amount of PEEP and FiO2, there's still a fair amount of ventilation perfusion mismatch that is a marker of it's a marker of lung injury, then you would be dealing with a you probably need to consider under this circumstance that even though the patient is perfectly synchronous, the amount of work shifting is very high and the transpulmonary pressures are elevated. And under those circumstances, you would be considering that sedation or paralysis would be the next step, obviously, or addressing what's causing this, right? It could be that the patient at that moment is anxious because X, Y, or Z, or you were turning them, or they just had a colic, or they were having a bowel movement. I don't know, something along. So you have to recognize the cause, but if the goal is safety, there is not a good mode that will avoid this amount of PMOS. If your goal is comfort, then the question is, well, this is not a balanced work of breathing. And if the cause is not addressable, anxiety, pain, acidosis, then and you want to support this work of breathing, then a mode in which you have either proportionality or constant pressure would be better. However, with this amount of PMOS, you would be highly concerned about the self-induced lung injury. And then obviously, if your goal is liberation, and this patient is asking for freedom, but I would say with the amount of PEEP that the patient is and FiO2, the patient likely not in that window of appropriate or safe extubation, and that would not be the case.
And
so
Miguel
regardless,
ask if there's a correction factor on the calculation of PMOS.
Yes, there is, and I think Miguel put it on the screen, and it's you multiply it by 0.75, so 75% of that number is the amount of PMOS generated. I also want to address a question that came out, and this is an go ahead, Adi.
Yeah, you know, all the information you're talking about is available in the ventilator. The ventilator knows the compliance, yes. It knows the volume, it knows the pressure it's supposed to give. So it knows the work that it's supposed to do. And if it doesn't do that amount of work, the rest is what the patient did. So I don't know why the ventilator is not giving it to us. It's an engineering issue. It's the data are there.
This ventilator does calculate the work of breathing in joules, but I don't think that we ever use this clinically or have put it, or the measurement is has moved into active work into our practice, Adi. But you're right; it could potentially, I presume, give us an estimate of the PMOS for certain modes. Rob, you know better this.
Go back to the previous slide. I want to show you something.
Yes, sir.
Look at the value for compliance. Dynamic compliance, 86. That is not a believable number.
Yeah, that's very high.
Yeah, you can't measure compliance if there's a lot of PMOS involved.
Right.
So you can't do any calculations based on compliance for any reason, whether it's work or estimating tidal volume or anything.
Yeah, absolutely. So this value is it's fake under these circumstances. And actually that talks about why the pressure is also going down, right? The ventilators is misunderstanding this as an improvement in compliance.
Doesn't know the difference.
Doesn't know the difference.
And somebody asked earlier on the chat, if you had a brain dead patient, or if you had, I suppose, a paralyzed patient, would the pressure go up and down, or would it stay constant? And the answer is, it goes up and down if the compliance and resistance goes up and down. In other words, if the time constant changes so much for some reason that you can't deliver the tidal volume at target, it will just change the pressure. So you don't have to have an active PMOS to see a change in the P vent with adaptive targeting.
Yeah, and actually this is, I mean, there's like 7 important items with that comment about the brain dead patient. I would say yes, without a doubt, it will change with changes in resistance and compliance. But the absence, when you have somebody that is brain dead and it's automatically triggering, sorry, it's triggering, and you think that it's the PMOS, and you don't see any changes on tidal volume or evidence of PMOS, you should rapidly start thinking that in this patient with brain death, the etiology is actually false triggering, and we have seen several cases that highlight that. So just so that you're aware, Javier. Very good. All righty. With all of this, it's 2:30. We have achieved our tasks, which was to review this topic. Here is the CME for CCF caregivers. Here is the CRC for our RTs. Please take up the codes, and please thank you very much for your time and learning. And here's our Twitter and our emails if you want to send us, and prior episodes for the videos. Thank you very much and have a great afternoon.